Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a hypermature cataract with some degree of intumescence and a very hard nucleus. Let us observe this surgery. This is the main incision with a 2.8 mm steel keratome, and this is a side port on the right side of the main incision by the keratome itself, about 3 clock hours away. Now I inject an air bubble, fill up the anterior chamber with the air bubble, and beneath this air bubble I apply trypan blue dye over the anterior capsule of this hypermature cataract. You can see that the eyeball has turned to the right. This is the right eye of the patient, and the eyeball has turned temporarily because of the peribulbar block, and the case has become more tough because the eyeball is not looking straight, it is looking to the right side. However, we have to manage this case. The antechamber is now filled up with 2% hydroxypropyl methyl cellulose. We can use a dispersive visco along with cohesive on and employ the soft shell technique in such cases, but I am using only the 2% SPMC. This is a side port on the left side of the main incision, and now I use these forceps to make the eyeball looking straight up towards the microscope and do the rhexis. As I make a puncture, some fluid comes out, turbid fluid comes out, which indicates high intralenticular pressure. And in such cases, it is always advisable to do a 2-stage rhexis. And when you use only SPMC for this, I call it Mohanta's mini rhexis. And now this is how I reduce the intralenticular pressure. After aspirating some cortical lens matter and the turbid fluid, the antechamber is filled up with 2% SPMC again. And now a Vanna scissor is taken. A small cut is made at the margin of this small rhexis. A utrata forceps is taken, and this rhexis is enlarged. But in this case, it was not an optimum sized rhexis. The cataract was very hard and the nucleus is very big, and this size of the rhexis is not adequate for this. But since I have already made this, I tried for some time to manage the nucleus. I go in, aspirate some superficial epinuclear lens matter, expose the nucleus, and now I try to employ my technique, which I call submarine chop. The tip goes into the substance of the nucleus, goes for a distance, and now as it goes near the rhexis margin, I try to crack this nucleus. But in this case, it was not successful, probably because I was not deep enough. And see, the stress on the rhexis margin. The rhexis margin at 3 o'clock is getting stressed by the chopper. This happens when the rhexis is small. The rhexis margin gets stressed, the zonule also gets stressed, the nuclear pieces doesn't tend to come easily. All these complications happen when you do a small rhexis. So in hard cataracts, always do a large rhexis, more than 5.5 millimeter. size of this rhexis is about 5 mm or little less than 5 mm. It is not advisable to do a rhexis less than 5.25 mm in hard cataracts, according to my very humble opinion. And now this is how I'm trying to manage this nucleus. I got 1 or 2 pieces free. I'm trying to remove that. Yes, I'm emulsifying and removing those pieces to make some room for the larger part of the nucleus on the left side, which is where the nuclear pieces are not free. I have got only some partial cracks in that piece. So about 1/3 of the nucleus has been removed, and now I go and I find that I'm trying to crack this nucleus. I've got a good crack, but the pieces are joined to each other centrally, and there is a stubborn plate at the center where all these pieces are firmly adherent, and they are not giving in. So my plan is to do some manual work at this time. First, I plan to enlarge the rhexis, and I try to enlarge from 1 o'clock to 4 o'clock. So make a cut here, take the uterine again, lift the anterior lip of the main wound, and enlarge the rhexis from 1 o'clock to 4 o'clock. And this should be enough. Now I go behind this piece with a blunt instrument, and over this there's another hook, Sinski hook, and the blunt instrument behind is my chopper, which is known as Mohanta's chopper. It is just a modified Sinski hook, little thicker and stouter than a Sinski hook. So this portion, this almost 2/3 of the nucleus, has been divided into 2 free fragments. The larger fragment is still not free. I try to divide the larger fragment into 2 pieces, and now I am trying to manage the larger fragment first. I am using almost 85% ultrasonic energy, and that's why there's some cavitation bubbles at this time. So I asked them to reduce the ultrasonic energy, and now the vacuum is 400 millimeter of mercury and flow rate is 40 ml per minute from the beginning till now. And this is the other part. I'm always at the iris plane and never near the corneal endothelium, and most of the time I'm at the central part of the anterior chamber, where the antechamber depth is most. And now at this time I'm trying to remove the nucleus first and keep the epinuclear shell. And now at this time I have asked my assistant to go to Phaco 3 mode, that is epinucleus removal mode, where the vacuum is 250 and flow rate is 25. At this time I remove the chopper and try to manage this epinucleus. My idea was to prevent leakage from the side port. As I went again with the chopper, I caught the posterior capsule here, and fortunately I could release it in time and I come out. And now my plan is to use the IOL scaffold technique to emulsify this last small bit of nucleus. So inject visco, fill up the anterior chamber and the capsular bag, and inject the intraocular lens in the capsular bag. This is a hydrophobic acrylic single piece monofocal intraocular lens. The lens is placed in the capsular bag. The piece is brought at the center, and then I go again with the handpiece and remove it in 2 seconds safely. And now my job is to remove the visco, and there are some cortex here and there. I want to remove that by the bimanual irrigation aspiration cannuli. You can see some cortical matter at 6 o'clock, 8 o'clock. All this cortical matter was removed, and then I come out, close these side ports by hydrating corneal stroma, do a final lavage of the anterior chamber, and see the main wound. I have used almost 80% ultrasonic energy in continuous mode, but the wound is clean. The integrity of all the wounds are checked and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, compassion, and great surgical competence.